I was really excited about this topic today, understanding and managing medical emergencies. These are just some things that every healthcare professional should know. Also, kind of depending on what aspect of healthcare you work in, medical emergencies can be a bit different in how we handle them. So, medical emergencies can literally occur anytime, anywhere. When I first started out in healthcare as a medical assistant, I actually worked in the emergency room. So, you kind of expect to see medical emergencies there. And everybody has a role, everybody knows what they're doing. It's kind of like a well-oiled machine. You know exactly what you need to be doing and where you need to be. But as I started to get into private clinical settings and healthcare offices and specialist offices, they don't see as many medical emergencies, but you never know when they're going to happen, right? People come to the doctor when they're sick, and sometimes they're a lot sicker than they think they are, or sometimes something happens while they're in the office, depending on what happens. And we're going to go over some of those scenarios. So it's a great idea to kind of know what your role is going to be, even when you're not in an emergency setting like the emergency room. Okay, so a medical emergency is basically anything that is an acute injury or immediate risk to life or long-term health. And we have to remember that medical emergencies, of course, can happen at any time, even when you're not expecting them to happen. So it's important to kind of expect the unexpected when you work in healthcare. So we're going to talk about some common medical emergencies that you might see in the clinical setting. These by far are not all of them, but these are kind of the top 5 that I came up with from my experience and in my research. So the first one, and by far the most common, is cardiac events. Okay, whether that be an actual heart attack or myocardial infarction or just a cardiac event associated with a heart issue. And we're going to talk about each of these in detail. Excuse me. The second one would be a stroke. Third would be seizures. Fourth would be anaphylaxis, which is a life-threatening allergic reaction. And 5th would be diabetic emergencies. Of course, there are so many other medical emergencies that can happen, but these are the ones we tend to see in the clinical setting if they are going to happen. So it's important to kind of focus on these top 5 and, of course, learn about other ones in general as well. Okay, so let's start with the most popular, cardiac events or cardiac arrest, okay? This has been definitely a medical emergency that's come up in my time as a clinical medical assistant. I worked in family care and internal medicine for a long time. And we would have patients that would come in and they would make an appointment because of symptoms they were having, okay? And a lot of times the symptoms that they were having were not typical what you would think of heart attack symptoms, okay? And when they came into the office, sometimes they were actively having a heart attack and they did not know. So it's important to kind of understand the symptoms associated with cardiac events. So in most cases, cardiac arrest happens without any warning signs, which is kind of crazy. You would think that you would have these symptoms ahead of it, and sometimes you do. But a lot of times they just kind of happen out of the blue after you've been having a really normal day. And it's really important to understand that everybody presents differently with cardiac events. So some of the common symptoms would be rapid, shallow breathing. A lot of times people that are having heart attacks claim that they feel like they can't catch their breath. They have shortness of breath. Arterial hypotension. So they start to get some low blood pressure because they're not getting enough blood flowing through the arteries and enough oxygen. Sometimes mental alertness can be decreased. People that are having heart attacks are not getting enough oxygen, right? So that can alter their mental status. Of course, collapsing without warning, having heart palpitations, where all of a sudden you're having arrhythmias or something called PVCs, preventricular contractions, which will feel like a skipped heartbeat or just a speeding up and slowing down of your heart rate. And fainting is also common too because of the lack of blood flow. So, when we see this in the office, we need to be prepared. Every medical office, even if it's just like a family care office, should have a crash cart. Their staff should be trained on the crash cart. There should be somebody that is monitoring that cart, making sure everything is stocked. There's no expired medications or equipment. The oxygen is full, things like that. And there should be training on what to do in the event of a cardiac arrest. So it's really, really important to understand the presentation of cardiac arrest. It is different depending on the person and sometimes depending on the gender of the person. A lot of times, male patients will have gastrointestinal upset and nothing else. We've had a lot of patients saying, my stomach just hurts. I feel like I have heartburn. I feel nauseous. I think I have food poisoning, and they're having a heart attack. And men are more likely to have the chest pain, the chest heaviness, if they are going to have it. Whereas women oftentimes present with shoulder blade pain and arm numbness on the left side. They rarely say that they have like the chest pain. Sometimes they do, but they tend to feel it more in the back. And then this could be different for anybody. Like what's normal for a woman's symptoms could be different for another woman and for males and vice versa. And sometimes it's not the typical holding your chest, saying you can't breathe, saying your chest feels heavy like you see on the movies when somebody's having a heart attack. It's different depending on the person. So we do have patients that oftentimes come in with symptoms they've been having. And when we run an EKG on them and do some things for them, we find that they're actively having a heart attack. So our job, if you're working in an office setting, is to stabilize the patient until emergency services come. We call 911 and we get our crash cart and we start our process, which I'm going to talk about in a minute after we go over the typical emergencies. Most of the time, medical offices are close to hospital systems, so that's a good thing. A lot of times you don't have to wait a very long time, but our job is to make sure we're stabilizing them. So obviously, if they are having a heart attack and they have stopped breathing and they do not have a pulse, we have to initiate CPR, which we'll talk about here in a minute too. And then there's some other medications and things that the doctor will give while they're stabilizing that patient. But the most important thing is to keep the blood flow going through CPR, to keep the oxygen going through your breaths. So the second one is a stroke. Strokes don't always present the same either, so they're kind of funny. We use the acronym FAST for strokes. F stands for face drooping. It's common to have face drooping on one side or the other. A is for arm weakness. It's also really common to have weakness on that same side as the face drooping with that arm. Speech difficulty. This is really common with strokes. A lot of strokes happen in the frontal lobe of the brain, which is where we have our speech production. So speech can oftentimes be affected when somebody is having either a minor stroke or a major stroke. And then T is time to call 911. So I have a kind of personal story with this. My aunt, who I'm very close to, actually had a stroke when I was with her. And she was talking like she normally does. I think it was like a holiday. We were cooking out and a bunch of family was there. And she was telling me a story. We're Southern, so we talk a lot. And all of a sudden, she just lost her words. She wasn't having face drooping. She wasn't having arm numbness at the time, but she could not keep telling me the story she was telling me. And I was like, what's going on? And she was like, I just can't, I can't say what I'm trying to say. And I instantly knew, right? So we called 911. She got to the hospital and she was okay. And her speech came back after some physical therapy, but it's still not quite where it was. But speech is a big one. Sometimes not all of these symptoms will happen. Sometimes it will just be a facial weakness and nothing else, or speech problems and nothing else. So it's important to remember that not all of these symptoms have to happen for you to think that it might be a stroke. It's always good to get it checked out if you're not sure. So seizures. Seizures is another common medical emergency. The good thing about seizures is they have the symptom. You are actively having the seizure. It's kind of easy to know what's going on with that, right? So the symptoms, of course, are the convulsions, sometimes unconsciousness, right? There is a lot of, I think, panicking that happens with seizures. And if you're not in healthcare, you don't really do the right things with seizures. And it's not anybody's fault. We just do instinct, right? When somebody's having a seizure, we want to protect them. But what we need to do is not panic, okay? If the seizure presents itself, it's pretty, self-explanatory. It happens and you can see it's happening. If you're able to have the patient get down where they're not going to fall, turn them on their side if you're able to. Sometimes vomiting is a problem with seizures, and you don't want them to aspirate and breathe in that vomit and get it in their lungs. Stay with the child or the person that's having it. Make sure everything's out of the way, that they can't knock into anything to further hurt themselves. So you're going to kind of secure the area. Okay, don't put anything in their mouth. Do not restrain them. They need to have the seizure. Okay. We hurt people more when we're trying to hold on to them to get them to stop. And I think that's a lot of people's first instinct, is to like, oh, I need to hold them, right, and protect them, and they're scared. But really, we have to let them have the seizure, and we need to kind of just protect the area. Miguel, a minor stroke usually doesn't cause any damage and it will go away on its own, but it is a precursor to like a risk of having a more serious stroke later on. So we call mini strokes transient ischemic attacks. And usually there's no lasting damage, but if you have one, you're at like a 50 or 60% more increased chance of having a bigger stroke later in life. So you'll have to make some lifestyle changes and medication changes to prevent that. So with seizures, it's really important to know your patient. If they have a condition where seizures are a thing, like epilepsy, then as long as the seizure hasn't lasted longer than 5 minutes and they haven't hurt themselves, usually we know what to do with that. The patient is taking a medication. Maybe we might prescribe something. Maybe we suggest they go get checked out after with their doctor. But if it's somebody that's never had a seizure and they're not diagnosed with any condition, we need to call 911 because it could have been something else causing that seizure that's going on, right? And we need to get them to the emergency room so that they can do further testing and imaging to find out why they're having that seizure. So anaphylaxis, this is our fourth really common one. Anaphylaxis is a life-threatening allergic reaction. Most of the time we can tell this is going on because the patient will have trouble breathing, okay? They will have severe swelling and trouble breathing and respiratory issues. A lot of people think they're allergic to something if they have a reaction, but anaphylaxis is different. So when you're severely allergic to something and you have anaphylaxis reactions, you have to carry an EpiPen with you. There's a lot of people that are allergic to bee stings or food allergies like nuts or shellfish, or latex is another one that can cause severe anaphylaxis. If you get a rash and you're uncomfortable, you don't have anaphylaxis. You may be a bit allergic to that substance or whatever, but when you have anaphylaxis, your throat usually closes up and you cannot breathe and you will die without your EpiPen injection. So anaphylaxis, sometimes we see it in the office, but usually people that are severely allergic know what to stay away from, right? And the only time they have some sort of a reaction is if they come into contact with something and they weren't expecting to. Like maybe they know they're allergic to nuts, but they go to a restaurant and order something and it was cooked on a pan that had cooked something with nuts before, and they're that allergic that even a trace of it, right, can affect them. But what we do see in the medical offices, and I've seen this happen, I wouldn't say a bunch, but at least enough to talk about, is medication reactions. So in the office, we give medications to patients, right? If they've never had the medication before, they have the ability to be severely allergic to it without knowing. One thing that we used to do in the office that I started doing very early on was anytime I had to give a medication to a patient that the doctor ordered, I would give it to them at the end of the visit and I would have them hang out for about 10 minutes. Usually I'd tell them, I'm going to get your paperwork and stuff for you to check out, hang tight. And I would keep an eye on them. And after 10 minutes had gone by, I would give them their checkout stuff, but I would look them over. You're not having any rashes. Are you breathing okay? I would look in their mouth just to make sure they were okay. And you guys, it doesn't matter if it's Tylenol or like some sort of a big antibiotic. People can have allergic reactions to anything. You could give Tylenol to 100 people and nothing ever happens. And then that 101st person could be allergic to it. Right. So we have seen people go into anaphylaxis when we give a medication because they never had it before and they didn't know they were allergic. So we need to make sure we carry that stuff in our crash carts at the offices, and epinephrine, EpiPens, things like that, so we can take care of it. So some common things that happen when somebody is having a severe life-threatening allergic reaction is it will start with face and tongue swelling, and they might even have some congestion. And then it grows, okay? The longer it goes on, they start having trouble breathing because their throat is closing up. This can cause them even to be nauseous or to vomit. They can have rash or hives, flushed or pale skin, a weak pulse or a rapid pulse that can both happen, wheezing because they're having problems getting air into their lungs, throat tightness, and if you don't act right away, it will just keep closing up until that person will not be able to breathe without help, right? So those are some of the common symptoms of anaphylaxis. And if it's going to happen, if somebody is that severely allergic, you guys, it will happen within that 10 minutes. So I always have them hang out for 10 minutes because if they're that severely allergic, within 10 minutes, they'll start having those symptoms. So that's what we see with anaphylaxis. What is the dosage for epinephrine? Elizabeth, I am not sure. I think it depends on the person's size. If it's a kid, then it's probably like a smaller dose, but it depends on their weight. But the EpiPens come pre-dosed. So I'm really not sure on that one. I'll have to check on that. But it's really nice because they come pre-dosed and you just Okay, so the fifth one is diabetic emergencies. Unfortunately, this happens a lot, especially here in the United States. We are riddled with diabetes, you guys. This one is kind of near and dear to me because I am a type 1 diabetic. I got diagnosed when I was very young. And type 1 is the type where it's autoimmune and your pancreas does not make any insulin. So you literally have to do insulin for everything that you consume. Type 2 diabetes, however, is insulin resistance, where you're still making insulin, but you're basically not making enough to keep up with your bad diet. It's diet related, and it's lifestyle related most of the time. So we do see a lot of diabetic emergencies. Type 2 diabetes is way more common than type 1. And a lot of times we see either hypoglycemia, which is a very low blood sugar, or hyperglycemia, which is a very high blood sugar. So with diabetes, you're giving yourself medications and sometimes even insulin for type 2 diabetics. Sometimes they even have to go on an insulin to control their diabetes. And insulin and regulating your blood sugar is a very tricky thing. It's a very slippery slope because you want to give yourself enough insulin to cover what you're eating, but sometimes we give too much. You take your insulin before you eat, but what happens if your full and you don't want to finish the whole meal, and then maybe you gave yourself too much. So we see a lot of hypoglycemia, okay? In the office, we have glucose injections, and we also have glucose tablets if they're coherent enough that we can have them chew a tablet, and this usually fixes it very quickly. Hypoglycemia is when we see a blood sugar that's kind of like 50 or below, okay? I mean, we want to see that between 70 and 110 at all times. 60 is kind of low, but at that point you'd have a snack. But once we start to get to the 50s and below, that's where the problems start happening, okay? The patient could start feeling very tired, very nauseous, very weak. They could even pass out. So we want to make sure that we're really educating our diabetics about checking their blood sugar before they eat and then 2 hours after they eat. And if they are having any symptoms, to make sure that they're checking their blood sugar if they're feeling fatigued or they feel off. I've had a lot of hypoglycemic incidents. I don't really have many problems with higher sugars because I've been doing this for a long time, but I will get lows a lot. And you kind of can tell you just feel off. You feel like very hazy and tired. So in the office, we want to make sure that we have glucose tabs ready for them. And anything else that we might need to give them. We usually keep juice or crackers or something for somebody that's maybe had given blood, or if they're hypoglycemic, we have that for them. If they have a hypoglycemic event where they pass out, then we probably will call 911. They probably need to go be evaluated for a little bit to make sure everything's okay. Hyperglycemia is a very high blood sugar. High enough to be an emergency would be kind of like the 300s and above is usually what we would do. This is not a quick fix, okay? This would require you to go to the emergency room because you might need to hang out and be on an insulin drip for a little bit. But then again, you have to be careful with insulin. It can drop you very low. So sometimes they just have to monitor that for a little bit. If somebody has really, really high blood sugar, they could have headaches. They could have vision issues where they're not being able to see clearly. They could be irritable, have mood shifts. So with hyperglycemia, this is going to be something that insulin's going to have to take down gradually, okay? And then kind of get a dietitian in there, get your doctor involved to maybe adjust your doses and figure out why it's happening so that you can help to kind of gradually fix it. It's not something that's just going to get fixed in like an hour. Okay, so some of our ways to deal with medical emergencies, first and foremost, is BLS, basic life support. As a healthcare provider, you're required to be certified, a BLS certified. Your work usually takes care of that for you. They make sure you go get recertified every 2 years and get trained on how to do that. With CPR, if you guys haven't been certified yet, you learn to do 30 chest compressions and then 2 breaths, and then you restart your 30 chest compressions. This is if somebody is no longer breathing and does not have a pulse. Also, we use an AED defibrillator, okay, if it's available, and we're trained on how to use that as well. With your crash carts and with your equipment in a medical office, there's always a defibrillator. Usually the doctor will run that part of it, but you are trained on it as well as a healthcare team member. A lot of bigger areas like malls and schools and places where there's a lot of people, usually standard are starting to have defibrillators there as well in case there's some sort of an emergency like that, and that the staff is getting trained on that too. So I kind of like that they're starting to promote that in the busier, bigger areas. Okay, so for CPR, we feel for a carotid pulse. That's the carotid artery on our neck, okay? And then you keep pulse checks for 10 seconds or less. So you want to keep it there, but not be using up your hand and keeping it there the whole time. So you want to just kind of recheck and recheck. If there's no pulse, then you begin CPR, which is your 30 chest compressions followed by 2 breaths. it says place if heel of hand on lower half of sternum. So it's kind of like right in the middle of the breastbone. And this, you guys, this is for an adult and older children. Place the other hand on top and interlock your fingers while you're doing your chest compressions. Keep your arms straight and press down 2 to 2.4 inches deep. If you guys have ever done CPR on somebody, it's kind of graphic. Okay, you can feel like the rib cage popping a little bit, but then you know you're doing it right. You would rather them having their heart pumping, than risk them having some rib issues or something afterwards. We want to make sure we're saving their life. Oops, let me go back. Sorry about that. Okay, so we want to make sure we're opening the airway. So we tilt the chin back, okay, and it helps to open up the airway. So when you're giving those 2 breaths, we know they're getting into the lungs. You give the first breath over 1 second. So these are not little breaths. We're giving a breath. And then you take a breath yourself and give the second breath, and then resume your chest compressions. So when we're deciding what we need to do for our patient when they're in a medical emergency, we like to use the ABC acronym: airway, breathing, circulation. Okay, so when somebody goes down or somebody's having a medical emergency, especially if they're not awake, okay, we want to do their airway. So we want to prioritize their airway to see if they are breathing. Okay, one way to do this is to lean your head down to listen if they're breathing. You can also see the chest rising and falling if they're breathing. And then we're going to assess circulation. Do they have a pulse, right? We're going to check their carotid. Do they have a blood pressure? If you have time or somebody else to check a blood pressure, is there one? Is there any bleeding, profuse bleeding? Is it that kind of a trauma where somebody's been cut and they're bleeding out? So airway, breathing, circulation is what we do first. Then we decide next what we're going to do based on what we find. So this kind of a typical crash cart, okay? The ER is kind of riddled with them and other equipment, but in regular offices, this is what we usually have. There's always a defibrillator on top, okay? And you're trained on how to use that. There's a disposable kind of lock box, okay, that's usually you can easily get the key and open it, that has all your medications you might use. There's usually a wire basket with things to wash your hands or things to cleanse with. There's a needle box if you do have to draw up any medications. There's usually a waste bin, a handle. There's always oxygen on the side. You always want to make sure your oxygen tank is working and that it's full. At the office I used to work for, every month we had a crash cart check. We would go through everything. We would make sure none of the medications were expired. We would make sure the crash cart was stocked. We would test the oxygen tank to make sure it was full and it was working. Okay. And then there's other equipment there for, like, if there's any bleeding, there's gauze pads, there's suture kits, there's all kinds of different equipment in that crash cart. And it's going to be the office's job to make sure that that is stocked and ready to go. Usually we had to go over it with kind of a form and check off everything. And then we had to show it to the physician so that they could check it off. And we did this every month. I think it's kind of just depends on the office that you work at, but there should be some kind of policy in place for that. So during a medical emergency, communication is key. Like I said, when I first started, I worked in the ER. Everybody knew their job. Medical emergencies came in all the time. It was the emergency room. Everybody knew what they were supposed to do. We all worked well together. Everybody anticipated everybody else's needs based on their role. But in the office, we can go long times without having a medical emergency. That's what we hope for, right? We're just treating patients that are sick or are coming in for health issues. And we hope that we don't have a medical emergency, but we need to always assume that one could happen, right? But because it can go long periods of time without having one, sometimes training for it or being prepared for it or looking at your crash cart can get put on the back burner, right? So it's really important that first you make sure that your workplace has policies in place for what to do if there's an emergency. Talk about who works there, who's going to be responsible for what. Practice, go through a pretend medical emergency and practice how you would handle it. Communicate with your staff so that everybody knows what their role is going to be, so that when a medical emergency happens, you're not panicking and going, I don't know what to do, or more than one people aren't doing the same thing. So you want to make sure that you guys practice that at least on a regular basis. So make sure that you're communicating with your staff. Everybody knows what they're doing. You guys are doing some kind of training on what to do in an emergency, and somebody is responsible for the crash cart and everybody's trained on it. It's also really important to remember legal and ethical considerations when you're working with patients. We can't document things when we're running an emergency, right? You can't stop and be like, oh, hold on, let me type this in, because time is of the essence with emergencies. So we want to make sure that we're remembering everything we can. And as soon as the emergency is over and they've been transported to the hospital, that you're documenting right away so that you don't forget anything. If you're able to get consent from your patient, like if they're still coherent and awake, do it. Tell them, hey, we're going to have to do some emergency care on you. Is this okay? Get at least a verbal from them. Let them know what's going on with their care. Okay. Remember all the rights of patients. They still matter in an emergency. To have good quality care, to have their information be confidential, to have clear information, to have access to their medical records, hopefully when they're better, to give them information about what you did for them and educate them on their health issues, and human dignity and even spiritual assistance, depending on the patient's culture. But we have to remember their rights. If they are incoherent and they have stopped breathing and you can't ask them, of course, our job is to help them, right? To stabilize them so that they can get to the emergency room. So sometimes we're going to have to do things without asking them, but we want to make sure we're documenting as much as we can, protecting them, protecting ourselves. So we do see emergencies in pediatrics. This is with kids. We treat pediatric emergencies the same. The only thing that will change is maybe the way you do CPR. We do chest compressions for older kids and adults, but for infants, we use kind of the two thumbs to press, okay, so that we're not putting too much force on their rib cage because they're much smaller. But it's the same compressions, same breaths. Also, medications will change based on the size of the person as well. Pediatric emergencies can be very hard because they're kids, right? So we need to remember that it's the same thing. We're going to stay calm. We're treating a patient. Try to get it out of your head that they're little. I know that's easier said than done, but time is of the essence for our kids too. So we want to make sure that we are running that emergency the way we need to and worrying about stabilizing them. But definitely it's harder working with kids because you never want to see a kid go through a medical emergency, or anybody, but it's harder when they're little. So if the kid is awake and coherent and something is happening, calming them down, letting them know that you're taking care of them, reassuring them and the parents is the best thing that you can do. But if they're having an emergency, then you're going to have to do that emergency care, and you do it just like you would with an adult. We also need to consider some things with geriatric emergencies. This is anybody 65 years and older. Of course, not everybody fits that criteria. I know some 65-year-olds that could run circles around me, okay? But they tend to, at the age of geriatric age, have more health concerns, be on more medications. They have more fragile skin. It's easier for their bones to break due to osteoporosis and other things. So we need to consider those things, that other diseases they have, medications that they could be taking that could interfere with some of the emergency medicines. And then fragile skin, fragile bones. So just keep that in the back of your mind as well. Age does matter with medical emergencies between pediatrics, adults, and geriatric adults. Another medical emergency that you can have happen is mental health emergencies. Okay, if somebody's having a mental health crisis, this is also considered an emergency if it's a danger to that person or somebody else. The best thing to do is, again, to remain calm. Okay, I used to tell my students, I tell them this now, I always tell them that you're going to deal with difficult situations, and you have to remember that it's nothing personal, it's just part of the job. But sometimes people can have mental health issues that can lead to a medical emergency because they can become suicidal, or they can try to harm themselves, or they can try to harm somebody else. So make sure that you stay calm, make sure that your safety and others is the first priority, because you can't help anybody if you can't, if you get hurt. So make sure that if there's a situation where somebody has a weapon or something like that, that you are maintaining the most safety that you can. Okay. And then of course, always involve mental health professionals. If you're able to get past that emergency, make sure mental health care is the care that's coming next. Of course, if something emergency happens with medical, like they do try to hurt themselves, then you're going to have to do that emergency care too. You just have to make sure that the health professionals, mental health professionals, follow up after the care is given. So as a provider or a healthcare employee, it's important to have self-care for you. I know we're talking about medical emergencies, but working in healthcare can be very draining. It's called compassion fatigue, okay? Especially if you're working with a lot of emergencies. So it's important to be able to kind of, when you're home, rest, seek support if you need it. Counseling is available in healthcare, and it's really promoted for all healthcare employees, because sometimes we need that. Sometimes we need to talk to a professional because it's hard to kind of decompress after a day of a lot of emergencies or hard patients. So make sure that you're dealing with burnout and compassion fatigue. Everybody can get burnout from any job, right? But healthcare is no different and has a higher incidence of burnout. So recognize the signs. Are you starting to not enjoy going to work? Are you starting to get anxiety about the kind of day you're going to have? Are you getting depressed when you come home? And then once you've recognized it, get the care you need. Maybe it's just self-care. Maybe you want to start exercising or meditating, or maybe you want to change your schedule a little bit, or maybe you want professional assistance and you want to talk with a therapist. And sometimes it's just changing perspectives, taking some time off, giving yourself some self-care, and coming back with kind of a refreshed perspective of why you're doing this and why you're in healthcare. Either way, there's no wrong way to do this, whether you need lots of help from professionals or whether you're just doing it on your own. It's important to just recognize that compassion fatigue is a thing. A lot of us get it. Doesn't mean there's anything wrong with you. It just means that you need to really prioritize your self-care. So in conclusion, it's important to stay trained. You guys, healthcare changes so much all of the time. Stay trained and get that continuing education on the latest treatments, the latest ways to handle emergencies, all of the latest things that are coming out. Try to get as much training as you can so that you're that much more prepared should a medical emergency happen. Stay alert. Just because you work in an office that doesn't see medical emergencies doesn't mean one can't happen. They happen all the time. So always have it in the back of your mind that this could be a medical emergency, and stay alert to that. And save lives. When you're prepared, when you stay calm and you run your emergencies and you're getting your training and you're practicing and everybody knows their role, you're going to save lives. You're going to help to stabilize that patient for the hospital and transport. And that's what our job is if we're working in clinical healthcare and offices. And I've added some references that I used in my research here. You guys have access to these slides with this presentation. Please feel free to check them out. And let me go ahead and stop sharing. Does anybody have any questions for me?
Thank you so much, Jolene. I do see one question in the Q&A box. Regarding seizures, should 911 be called regardless if a seizure lasts more than 5 minutes?
I don't see that one. Is it in this one? Okay, I don't see it. So that depends. If it is somebody that has epilepsy or a condition that has seizures, if it's lasted longer than 5 minutes, then you would call 911. It's just protocol to do that. I would call 911 if it was somebody that didn't have a seizure issue and it was even a small seizure and it was only 2 minutes long, because you need to find out why they're having that seizure. But if it is somebody that has had seizures before and they're being treated for it, longer than 5 minutes is the standard of care. You call 911.
Thank you. I don't see any other questions in the chat, so I'll give folks maybe 20 to 30 seconds to type in any last minute questions they might have. Just as a reminder for everyone on the call, watching today's presentation does count as 1 hour of virtual shadowing, and a certificate will be emailed to all participants who stayed on for the duration of the presentation. So be on the lookout for that in your email within the next 2 business days. Still don't see any questions here, so we can go ahead and close out for today. Thank you all so much for spending your afternoon with us, and we hope to see you at the next webinar. Thank you so much, Jolene.
Thanks, everyone.